All right. Hi, I'm Kumiko Hayes. I'm the director of the Brain Imaging Research Center. Thank you very much for coming here today. We're very excited to have Professor Sue Whitfield-Gabrieli as a distinguished speaker for the BIRC Speaker Series. She has a BA in Biophysics and Physics from University of California, Berkeley, and then a PhD, ABD, I'm sorry, I don't know what ABD is, in theoretical, does everyone know? All right, I didn't go to school in the United States, so I apologize. It's a what thing?
It's a generational thing.
In theoretical mathematics and cognitive neuroscience from the University of California, Berkeley. She's currently professor of psychology and founding director of the Interdisciplinary Science and Engineering Complex. Isaac, or is that how you pronounce it? What? I'm sorry?
I did get a PhD in neuroscience eventually.
Yes. No, I said cognitive neuroscience, but PhD in neuroscience from UC Berkeley, yes. Did you want me to say that background? I like telling that story, but okay, I might get to it if I feel like it. Imaging Center at Northeastern University since July 2018. So she is just on her new job. She had previously held positions at Stanford and MIT, and the MIT job, which she continues to this day. She's exceptionally well known for her expertise in functional connectivity and connectomics, and has developed a number of tools for artifact detection and functional connectivity that many of us uses today. She has over 140 peer-reviewed publications and currently holds multiple NIH grants such as UOYs, R01s, and R61, R33 grants as PI. And it's particularly an honor to have her speak to us today because she was my first neuroimaging mentor when I was a postdoc at Stanford University. And in 2003, a while ago, which is the reason why I've had the fortune of being in neuroimaging research, continuing that today, and then have this job. So I'm really fortunate to be able to invite her back and to hear about her work she has been doing. Just wanted to give a quick anecdote. So a lot of people tell me that I talk fast, especially as an English language learner. I'm trying to talk really slowly right now. Sue talks really fast. So be aware, but she's extremely comprehensive, very knowledgeable. We're very excited to have her. I have a lot of other anecdotes and funny things we've done together, but I think I might have to save it at the end because I'm sure she has a lot of great information to share. Some of which we made a presentation together, make fun of John Gabrieli, who's now a professor at MIT. We made this fantastic presentation. I think that's the best talk I've ever given. John Gabrieli asked for the presentation, a copy of that again when he was moving out from Stanford to MIT, so I was very honored when I was a postdoc. And I think I have to say one more anecdote. So when I was first getting into neuroimaging, and I had all these bugs in the code and I didn't know how to figure it out. I was staring at her for 3 hours, 6 hours. I couldn't figure it out. She was extremely busy, but I went over and asked her, because she was my mentor, and said, I can't figure this out. It's not working. What shall I do? And he said, there's a bug. You should look at the code more and stare at it, and you'll find out what the problem is. So I think that was the best advice I've gotten in my programming sort of career. And so I tell my students that these days. So it's a great pleasure to have Sue. Please help me welcome her. Thank you.
Thanks so much, Mika, for that amazingly wonderful introduction. It's a true honor, and
I'll try to change the. Sorry.
Just want to say thank you, Kumiko, for that amazingly kind introduction. Kumiko and I do go way back, and she's just one of the most phenomenal students I've ever had, and she continues to do phenomenal research. And you can adjust the mic as well. And it's just a real honor and pleasure to be here today, so thank you for inviting me. I've had a wonderful day talking with many of you, and I'm looking forward to establishing collaborations and continuing our conversations. So thank you so much, Kumiko. It's really a pleasure to be here. So today I'll talk about clinical translation of resting state networks. So I believe that we're facing a true crisis today, especially in the United States, with young adolescents that are facing very severe psychiatric disorders like anxiety and depression. And many of us may know this because we have children, or many of you who are students may be suffering or you have friends or family members. But it's also quite evident, not only through the research we do, but also in popular magazines and other press. Here's an example where the New York Times Magazine highlighted an article asking why our teens are suffering from so much severe anxiety. This is an example of a survey that was done with 150,000 freshmen. And the survey indicated that the freshmen self-assessment of their emotional health hit a 25-year low. And unfortunately, there's many reasons for that. But it also showed that there's a 37% increase in the prevalence of 12-month major depressive episodes over the course of 2005 and 2014. And unfortunately, that's resulted in increase in suicide rates, and especially, unfortunately, there's been a threefold increase in girls as young as 10 to 14 in terms of committing suicide. And just last year, there was an article showing that children's hospital admissions for suicidal thoughts actions have doubled during the last decade. And I can speak to this from personal experience. I have a child, a 10-year-old child, and we were at the hospital, Boston Children's Hospital, for when she had an asthma attack, and there were many police officers stationed at many of the doors there. And I finally asked what was going on, and I was told that each police officer was basically monitoring a person who had tried to commit suicide or was thinking about committing suicide. That must have been an off night, I'm guessing, but it's a real phenomenon and a real problem. So let's take a step back. What can we do about that? Well, first of all, we know that there's many challenges in psychiatric disorders. I'm listing a bunch here, but I'll highlight a few, like 3 in particular in yellow. One is that detection is often late, and it's often done by crisis. Secondly, treatments are most often done by trial and error, despite the fact that we know there's great patient heterogeneity in treatment response. And thirdly, treatments often have negative side effects. They're only partially effective, and there's a high attrition. So we know that we can have many neuroimaging techniques to understand brain function and brain structure. Today I'll be focusing a little bit about connectomics. And what I mean by connectomics is the intrinsic structural or functional architecture of the human brain is elucidated by diffusion-weighted imaging or resting state connectivity. And I'll be specifically focusing today's clinical translation on resting state connectivity. So if you were to go to PubMed and just look and search for MRI or fMRI with many of the major psychiatric disorders, you may get about 20,000 publications. And those have been very interesting because they provided insights into the brain differences in psychiatric disorders. However, this knowledge has not fundamentally changed patient diagnosis or treatment. So how can we change that? Well, I'm going to hopefully convince you that maybe resting state networks may be able to ameliorate some of the problems inherent in psychiatry in 3 ways. So the first one we talked about is detection is late. Is it possible that resting state networks can provide early biomarkers which could potentiate early intervention and possibly prevention disorders? Treatments are based on trial and error. Well, is it possible that resting state networks could help us predict or figure out which treatment would be appropriate? It could be pharmacological, CBT, TBT, mindfulness meditation. Can we find out which treatment would be ideal for which patient? And then we would gear towards precision medicine. And finally, since many of the treatments have negative side effects, could we have novel interventions, interventions such as real-time fMRI neurofeedback, and other behavioral interventions that could ameliorate these symptoms? So today I'll talk a little bit about, with a very brief introduction of resting state networks, some of the promises and perils. I'll specifically talk about one default mode network that I think is relevant for psychiatry specifically. And I'll talk about the functional associations of the default mode network and self-reference networks, as well as behavioral correlates. So that will potentiate an understanding of what the functional pathology might mean in the case of neuropsychiatric disorders. And then I'll talk very briefly about how the DMN changes over the course of the lifespan. And that will be background to talk about how the clinical translation of resting state networks can happen. How can we use these resting state networks in terms of clinical characterization, early identification, and neuroprediction? Finally, I'll conclude by talking about how we can modulate these resting state networks. These networks are plastic, so how can we actually modulate them for a better outcome? So it was back in 1995 that Rt-fMRI discovered these resting state networks. What he noticed in a genius fashion is that if you were to look at task activation in the motor cortex by just simply finger tapping, what you'll see is motor cortex activated, not surprisingly. However, when you place a seed or region of interest in the left motor cortex and you look at the temporal correlations over time during rest, what you'll find is that the regions of the brain that rise and fall in temporal synchrony to the motor cortex are forming almost the exact same image here. So one you get with task activation, one you get through simply looking at the resting state temporal correlations. So the regions of the brain that rise and fall in temporal synchrony are intrinsic, spontaneous, extraordinarily low frequency fluctuations in fMRI gold signal that exhibit specific networks of the human brain in the absence of any test whatsoever. And here I'm just plotting a Behzadi figure that shows, if you are interested in MEG and EEG, you'll know these frequency bands. He coined 4 new frequency bands that people are now investigating more and more in EEG and MEG in relation to fMRI, the slow 1, 2, 3, 4. So here in resting state functional correlation, we're looking really here at slow 3 and slow 4. So why are resting state networks promising clinically? I'm just listing 3 important topics that could be very interesting to discuss in much more depth. One is that they're independent of the task and they're very easy to acquire. So that means that you're bypassing all behavioral differences in task performance. And it also means that you're able to scan pediatric populations, for instance, infants, as well as a wide range of clinical populations like low-functioning ASD. So you get rid of the task performance confound and you can scan more patients and infants. Secondly, they're very reliable or reasonably reliable and robust. And there's been a number of papers indicating that, but they're also importantly plastic. So you can modulate this with pharmacological or behavioral interventions. And thirdly, they're very easy to acquire and share. So many of you know the Human Connectome project that was initially with WashU and MGH Martinos. And then there have been many other HCP data sets where you have high resolution, spatial and temporal resolution data sets that are shared to the public. And the first one was with healthy adults. Then we have an HCP for disease, which we have for anxiety and depression, and then many other people have them for other diseases. And then we have the ABCD or longitudinal study, as well as the baby connectome, and many, many different large data sets that are now publicly available that you can just download and analyze. So it's this real paradigm shift, I think, in the way the functional imaging is working. Rather than having to collect your own data, you can download all of these phenomenal data sets, do your own analysis, ask your own questions, and then publish your data. So there's many different resting state networks, and the one I'll be focusing on a lot today is the default mode network. It was back in 2001 when Mark Brakel had shown that the regions of the brain that are more active during rest relative to a wide variety of attention demanding tasks are remarkably consistent. So one might imagine that if you're looking at the regions of the brain that are more active during rest, when you are not modulating the person's mental or emotional being, that you might imagine that people would be thinking of very different things, global warming, our current president, many different things you could be thinking about. So you would imagine that the activations would be quite dissimilar, but in fact they are quite similar. And since then, he's shown in another review that a figure that shows a graph analysis of all the papers that have cited his first paper. And what you see here in the cluster in blue are all the papers that cited his first paper that show the relationship of the default mode network with psychiatry. In other words, all clinical populations who have an aberrant default mode network. So this is an iconic figure from Fox in 2005, and it shows you how resting state, I think it's a nice way to show you how resting state connectivity works. Here he has subjects just lying in the scanner, healthy controls, and here you see a sagittal view of the brain. He places a seed or a region of interest in the posterior cingulate, and he looks at the temporal correlations over time during rest to the rest of the brain. And what you're seeing here is a threshold R map. So you're thresholding at 0.3. So anything that lights up in red or yellow, like the medial prefrontal cortex or lateral-parietal, it means it has, the time series has a higher correlation coefficient to the PCC time series than 0.3. And anything in blue has a negative correlation to the PCC over time. So if you were to take the time series and simply plot it in the MPFC and PCC, you would see them practically superimposed. That's here displayed in orange and yellow. So these regions of the brain, even though they're anatomically very far apart, MPFC and PCC, they're fluctuating in temporal synchrony, rising and falling together. And what's interesting is even though these subjects were not performing a cognitive task, the regions of blue, for instance, in central executive network, are negatively or anti-correlated. Even though they're not doing anything, you can actually see this central executive network, for instance, in DLPFC. And if you were to plot the time series of the DLPFC, you would see something like this in blue. And so what you'll see is that the blue is negatively or anti-correlated to the two core medial hubs of the DMN, the MPFC and PCC. So here, I'm showing you the magnitude of the difference between the time series of the MPFC and PCC versus something in blue, which is in the central executive network or past positive network, is actually quite meaningful. And in fact, the magnitude of the anticorrelations vary across people and across time. And today I'll be talking a lot about how the anticorrelations of the medial prefrontal cortex and the dorsolateral prefrontal cortex is very meaningful in the case of neuropsychiatric disorders. Before we were able to actually look at those, though, there's a couple of perils to this resting state analyses, especially with anticorrelations. One, we're looking at extremely low frequencies, so you get physiological aliasing, such as respiration. And secondly, motion artifacts are particularly insidious in the case of resting state correlations, as opposed to looking at the difference in parameter estimates of an fMRI task. So these are two huge problems with this type of analysis. So how can we fix that? Well, first, what is it? So Byrne and Manatini in 2006 showed that a lot of the regions of the brain seem to rise and fall in temporal synchrony just because we're breathing. So respiration will make regions of the brain look like they're functionally coupled, but they're really not. It's just an artifact of the respiration. And so he realized that basically the global signal, the signal of the entire brain, correlates with respiration. So why not just factor it out? Why not just regress it out? And so since this paper in 2006, people realized what we could do to reduce these false positives is to regress out the global signal. And that's wonderful because you can see here to the left, you see a lot of regions of the brain that look functionally coupled, but it basically is just false positives due to respiration. If you regress out the global signal, you see here to the right, basically just a little bit of the default mode network remaining. So you're getting rid of the false positives. However, Murphy and Manatini showed there's a problem with this step. And the problem is that by virtue of regressing out the global signal, you're shifting the distribution of correlation coefficients to being from all positive to being roughly centered around 0. And there's a mathematical equation that shows that the sum of the correlation coefficients have to be less than or equal to 0 should you be doing this step. So if you do global signal regression, you are mathematically mandating negative or anticorrelations, rendering them uninterpretable. So this is actually a really important paper in the field, I believe, because after this paper came out in 2009, many people continue to do global signal regression and just masked out the negative correlations or anticorrelations, which I think is doing the field a disservice because I think the anticorrelations are meaningful. So we wanted to find a different way of dealing with it. Finally, Ziad Saad also had a paper showing that global signal regression fundamentally alters within and between group correlations. He had a hard time publishing that at first because everybody wanted to do global signal regression, but he did publish it in Brain Connectivity, and it was to be the most highly cited paper in that journal for quite some time. So we decided to look for an alternative approach. So we found a paper by Behzadi and colleagues, and he had two different approaches. One was called an Anatomical CompCor, and one was a temporal CompCor. And the way this works is you basically take the brain, you segment the brain into gray, white CSF, gray matter, white matter CSF, and then you take a PCA decomposition of the white matter and CSF, and you regress that out in the first level general linear model. So we did a lot of experiments about this to make sure that this is actually a valid way to go. We wanted to compare it to the global signal regression. What you can see here is the noise reduction method in the left column. And what you'll see here is if you place the seed and the medial prefrontal cortex, what looks correlated to the MPFC, pretty much everything. What you'll see here to the right is the distribution of correlation coefficients, which is all positive. You may or may not see this as a 0 line here. After motion regression, not much changes. If you do global signal regression, there's a dramatic decrease in the false positives, and there's a mathematically mandated blue representing the anticorrelations. However, when you did the anatomical CompCor method, you also did see blue, albeit not as much as the global signal regression, but now we can actually report it and interpret it because we're not mathematically mandating these anticorrelations. So we also showed in this paper that we increased the sensitivity and specificity using this method. So the other big caveat with these kinds of analyses is that motion really is a problem. And so back many, many years ago when I was working with Nico back at Stanford, I had created a toolbox called ART. And what it does is it picks up outliers in the signal, the bold signal, as well as motion, and then you can just regress those out. So this is actually really important because many people have reported on differences in, say, the default mode network or other networks in children or elderly or different patient populations. And a lot of those analyses are fabulous. Some of them may, however, be confounded with the fact that children tend to move more, adults, elderly tend to move more, and many patients with psychiatric disorders tend to move more. So here's an example of a 10-year-old child. And we figured out some outliers where the child was moving too much. You want to ask the question, does the child have a default mode network? You place a seed in the medial prefrontal cortex, and you regress out the motion parameters, and then you regress out the motion parameters plus just a few outliers. And what you'll see is if you just regress out the motion parameters, you don't see a default mode network. You see a little local coherence within the MPFC. However, if you regress out the motion parameters and outliers, suddenly you'll see the default mode network. And this is important because there's been very high profile papers saying precisely the opposite, that children don't have the DMN as adults do. However, that could be because they're just moving more, and moving specifically relates to the anterior posterior correlations, as you see here. So for instance, like this is an example of a study, but there's many, many studies showing that patient group X doesn't have positive correlations. And again, it may be just moving. So here's pre-artifact detection, post-artifact detection. It looks like there's no default network here, but you can see it here. And this is just one example. I don't mean to pick out this particular one, but here there's an example showing that children 7 to 9 years of age don't have a default mode network, but adults do. And that may just be due to motion. So those are the two big caveats. So what we wanted to do was we wanted to create a toolbox that addressed both the physiological aliasing, which we did with the CompCor method, and the motion, which we did with ART. And so initially, we just wanted to do something very simple. We just wanted to do ROI to ROI connectivity using those data cleaning methods. And we also wanted to do seed to voxel, so looking at whole brain connectivity to a particular seed. But since then, my colleague Alfonso, who's been working really hard on this toolbox, has now made it kind of a one-stop shop where not only do you seed to voxel, but also many other analyses like dynamic connectivity, many different voxel-to-voxel analyses like MBPA and things like that, that you can be that I particularly use for clinical applications. But if you are interested in using, that's freely downloadable at ITRIC. So that's kind of the background, just to get talk about the perils and the promises of resting state. What are we actually looking at here that could be important for clinical translation? So I mentioned that we would talk about the default mode network. Well, it turns out that the two core medial hubs of the default mode network, namely the medial prefrontal cortex and the posterior cingulate, are related to self-referential processing. And people have tend to know that, but we wanted to do an empirical study to measure actually what regions of the brain are more active during self-referential processing relative to some baseline condition, and rest or resting state versus a baseline condition. So our baseline condition was a semantic judgment. We had people looking at trait adjectives, and the job of the subject was to decide whether the trait adjective was positive or negative. That was a semantic judgment. And the self condition was to decide whether the trait adjective described him or herself. So this is a conjunction analysis looking at which regions of the brain are more active during self-gradient semantic and rest gradient semantic. And it's precisely the two core medial hubs of the default mode network, MPFC and PCC. And the reason why I point this out is because if you have functional pathology in these regions and connectivity or in task activation, one might infer then that then there's a complication with self-referential processing in many neuropsychiatric disorders. Secondly, we know that the default mode network in the healthy brain, the greater you suppress the DMN, the better memory formation, fewer lapses of attention, and the better learning of a cognitive skill. So in other words, the more you suppress these regions through, let's say, mindfulness meditation or what have you, the better off you are. And then in terms of connectivity, what we found is that if you place a seed in the medial prefrontal cortex and look at the functional correlations during rest, the DLPFC here, what you find is those subjects, you're looking at a scatter plot here. So on the x-axis, you'll see the MPFC anticorrelations with the DLPFC. And on the y-axis, you'll see a complex working memory score. And what in each die as a person. So what you see is that the people who are more negatively or anti-correlated with the MPFC and DLPFC score better on a complex working memory task called the OSPAN. And that's been replicated a number of times and first shown by Michelle Hampson. So how did these anti-correlations change over the lifespan? Well, quite interestingly, there's a selective increase in these anti-correlations. And we've shown that here, where we looked at 83 subjects ages 8 to 24 with a simple resting state scan. We had MPFC seed. And what we found is that when you look at the MPFC seed, there was a selective increase in the DLPFC anti-correlation. However, when we broke down the ages from 8 to 24 into children, adolescents, and adults, what we found is a reversal of the functional architecture. So at first I thought there was a bug. I didn't tell my student this time to go back and figure it out. I actually did, but here you'll see that the MPFC and DLPFC is positively correlated for children. We've replicated that now many, many times. So children tend to have a positive correlation between the MPFC and DLPFC, and it doesn't start to get negative until you get into your teens, and that's typically driven first by females, and it's not fully anti-correlated until you get to adults. So this reversal of functional architecture of the brain is basically mirrored by all the different seeds. So here's the MPFC, left lateral parietal, posterior cingulate, and precuneus, and right lateral parietal. And what you'll notice that if you regress out the outliers, if you don't regress out the outliers, it looks like there's and you do a whole brain correlation with age, what you'll see is it looks like the DMN is increasing. These are the areas in orange, as well as the anti-correlations are increasing with age. However, after you regress out outliers due to motion, there is no longer this increase with age, the MPFC or any of the other seeds. However, you still do get the increase and the anti-correlations. And my understanding of that is basically the selective increase of anti-correlations is mirroring the selective increase in executive function. So basically, no matter where you look, you see this reversal of architecture. All these different seeds are flipping from positive, slightly negative, and more negative. So if you look at the other end of the lifespan, and you look at aging, we have 54 subjects. We had some elderly, some younger, and then we looked at the same seed, and we had another executive measure as working memory performance. And what we found was that the elderly did not have any frontal anti-correlations. So you see that all the blue are the anti-correlations to the MPFC, and here you have the younger and the older and the between group difference. And it's precisely the younger have nice healthy anti-correlations in the front of the brain. The elderly have 0, and you can see this measured by the bar plot here. And the biggest between group difference is the bilateral DLPFC. So as you know, if you look at the whole lifespan, you know, when you're developing, you're increasing your executive function and you're increasing your anti-correlations. However, at the end of the lifespan, you're decreasing executive function, fluid intelligence, things like that, which all go with a decrease, selective decrease in anti-correlations. And yet again, we did show that with young healthy controls who actually had some variants that we could work with, you can see that the degree to which the MPFC and DLPFC were anti-correlated significantly related to complex working memory. The more they were anti-correlated, the better complex working memory they had. Okay, so that's a long background, but let's switch over to clinical translation of these resting state networks. So what about schizophrenia? We know that schizophrenia is a very severe psychiatric disorder characterized by thought disturbances and perception of emotion and neurocognitive deficits. And we know there's a genetic basis for schizophrenia. So excuse the end, this was done over a decade ago, but we started off with first episode of patients with early schizophrenia in order to minimize potential compounds due to chronic medication. And we also looked at first-degree relatives of patients with schizophrenia who were non-psychotic and non-medicated, and we had age-matched controls. And what we found, much to my surprise initially, was that there was a monotonic increase in the resting state connectivity of the DMN. You're looking at a coronal slice here, from controls to relatives of patients. So prior to this study, I always thought that schizophrenia was a disease of disconnectivity. And those are usually in task-related regions. But here we're looking at the default mode network, which is related to self-referential processing. And what we found was that there's a monotonic increase of connectivity. And if you were to do an ANOVA, we found that it was precisely the self-reference nodes, the MPFC and PCC, that were hyperconnected both for the relatives and and even more so for the patients. And moreover, the degree to which the MPFC and PCC were functionally coupled during rest, the more they had psychopathology. It's as if these regions in the brain were hijacked and they are not able, so if you're schizophrenic, you may be engaged in paranoid ideation. This is also true for depression, so you may be engaged in rumination. But the degree to which these two regions of the brain are functionally coupled during rest, the more psychopathology you have. And then when we looked at the anticorrelations, if we place the seed in the MPFC seed again, the controls had, now you can see this in red, nice bilateral DLPFC anticorrelations, both during rest and during task. And then when we did it in ANOVA, it was a right DLPFC and Prominence 46, that the controls had a nice healthy anticorrelations, relatives less so, and patients less so. And it's related to cognitive impairment. So one possible way we were trying to interpret all of these anticorrelation differences, well, maybe this anticorrelation, or the magnitude of the anticorrelation, may reflect a push-pull relationship, or the ability to toggle between internal processing when you engage in your internal thoughts and self-referential processing versus external processing. So since we did that study, one of the things in neuroimaging we're trying to do is trying to replicate, because it's becoming hard to do that. So this particular finding has been replicated a number of times here. So how about using resting state networks to characterize ADHD? We know that ADHD is characterized by inattention, hyperactivity, and there's an increased diagnosis of it. However, interestingly, 40% of children with ADHD outgrow or remit their diagnosis. So is there a neurobiological distinction between those who persist and those who remit? That's what we wanted to find out. But in the before we did that, we looked at Javier Castellanos' work, and he showed that if you place a seed in a PCC, what you'll find in controls is that you have a healthy functional correlation between MPFC and PCC, positive correlation as you would expect, and an anti-correlation in the dorsal ACC or cognitive control area, and nicely in the controls. However, in the ADHD group, you'll see that MPFC is completely decoupled from the PCC, and there's a significant reduction in the anti-correlation in the cognitive control region. So that paper was published back in 2008. So we took his exact same seed and tried to do a different study. We did a longitudinal study where subjects were diagnosed at childhood with ADHD, and then we did a 16-year follow-up. At that point, some remitted and some were persistent. So the question we had here is we had three different groups. We had controls. We had the ADHD who persisted and the ADHD who remitted. We also had a number of behavioral measures, of executive function. And so the question is, this is back into the Castellanos study, would the remitted look like the controls, or would the remitted look like the persistent? That was our big question. And what we found is that the remitted looked like the controls. So they normalized their brain pathology. Now the controls, the MPFC-PCC, of course, but the remitted now regained the MPFC-PCC, and the persistent still did not have it. So these findings are relevant for two reasons. One, the persistent is a replication of the Castellanos really provides a syndromic continuity between pediatric and adult diagnosed ADHD. And secondly, the fact that the DMN tracks the current diagnosis of adult ADHD really provides a neurobiological convergence with the diagnosis of adult ADHD, which has been a big question in the field. So that's great that the remitted normalized their brain. However, they weren't totally normalized. If you place a seed in the MPFC and look at the anticorrelations, the controls, of course, had the bilateral DLPFC anticorrelations, but neither the remitted nor the persistent had the anticorrelations. And perhaps that lack of anticorrelations may reflect a developmental history of having had ADHD. And again, the degree to which the MPFC and DLPFC are anticorrelated significantly related to executive function as measured by the brief across all three groups. So there's a number of other research I don't have time to talk about here, but if you are interested, I can talk to you afterwards. That's relating to how resting state networks can be useful for disorders of consciousness. So in one study, we were able to differentiate those individuals who were minimally responsive from unresponsible wakefulness, which is basically a vegetative state. It's very difficult to differentiate those. So here we're showing an example of how resting state networks can help with that. And secondly, we were able to look at the resting state networks of those individuals who came in with disorders of consciousness and be able to predict who would come out of a coma or minimally conscious based on the degree to which they had anticorrelations. So even though on average they didn't have anticorrelations as a group, the individual differences allowed us to actually predict when they came in who would actually come out of the coma. And then secondly, we recently published a paper where we're tracking the anticorrelations, and we could show that when patients came into the MGHER, we tracked their anticorrelations, and we could actually track the people who actually remitted. We could see that initially the anticorrelations went away with consciousness, and then as they emerged to recovery, the anticorrelations grew back. Other people have shown when you look at anesthesia, you can also see this type of thing. So it's as if the anticorrelations may be kind of a proxy for consciousness in some way. So let's talk about the real clinical translation of this work. So how can we really clinical translate? We know that current treatments for psychiatric disorders are inherently reactive to suffering and incapacity. Wouldn't it be great if we could actually have a more proactive approach in which brain networks pathology could be identified way before they develop the disorder? So here we have a study where we're looking at early identification of depression. We know that a child of a parent with major depression is a 3 to 5-fold increase for risk for developing depression. So here we have 30 kids who are at risk, meaning they had a parent with depression. And we had controls, and we had a behavioral measure called the CBCL, which is Childhood Behavioral Checklist. It's simply a form that the parents fill out, and they basically, it describes things like attentional problems or anxiety and depression and internalization. And this is highly predictive of a psychiatric conversion. So for instance, the CBCL of attentional problems is being used to screen for those individuals who might get ADHD. So before I talk about that study, I just wanted to mention that the Subgenual ACC here is known by vast literature to be related to depression and bipolar. It has less metabolism, decreased volume. Helen Mayberg does a deep brain simulation there. Mike Fox looks at the maximally anticorrelated region of the subgenual ACC to the DLPFC to preferentially target TMS to cure depression, which has worked much better than previous methods. And then Mike Grecius has shown that the subgenual ACC actually is hyperconnected to the default mode network. So the question one might ask then is the DMN pathology and depression a reflection of the state of depression or the neurobiological trait? So when we did our early identification study with these children who were not ill but had a parent with depression, we placed seeds of the default mode network precisely in the self-reference nodes, meaning the MPFC and PCC. And what we found is that the at-risk children also, just like the Mike Grecius slide a second ago, also had hyperconnectivity of the default mode network to subgenual. This is not mass. This is literally the only thing that came out of the study. So relative to controls, those children who are not ill at all had hyperconnectivity of the self-reference nodes to the default mode network to the subgenual. And moreover, the degree to which the subgenual were functionally correlated to the default mode network significantly positively correlated to the degree to which they were internalizing, which is predictive of anxiety and depression. Secondly, we looked at the left dorsolateral prefrontal cortex, and we found that the children who were at risk had negative correlations to the DLPFC, whereas controls had positive. And when we did a classification, logistic regression between the at-risk children and the control subjects, based on this resting state profile, we had higher accuracy and higher sensitivity and specificity that was superior to clinical ratings. So we followed up this research in various ways. With Ian Gottlieb, we looked at not only those who might be vulnerable, but what happens with people who actually are resilient. And then we also followed up these subjects 3 years later, the ones at risk that I told you about a second ago, and we were able to predict using the resting state biomarkers who actually would convert to depression. So that's just now MPFS. So let's shift gears a little bit and talk about prediction. So prediction is challenging. I'll just talk very briefly about a couple of review papers we have. One is what Tim Hahn wrote, and he was talking about kind of an overview of how we've gone from hindsight, where we describe symptoms, to insight, where we look at between group abnormalities and the functional goal signal. And now we're really moving towards prediction. Can we predict clinical outcome? However, there's a lot of challenges in this process. And one review we looked at recently, we looked at all the neuroimaging prediction papers that we could possibly find. And out of all those papers, 72 of those papers actually were just simply correlational. 61 of the 70 papers were correlational. So in order to do really good prediction analyses, you of course need to either do a nested cross-validation or to look at one of those large data sets that we were talking about before, where you have the Human Connectome project. It's another reason why we might want to download, hundreds and hundreds of data sets, because of people in the data set, because then you can actually train on one set and test on another to get the true independence. And then the other challenge of prediction is that even when you're doing this, you're really doing post-diction, right? You're looking, let's say you have a treatment for social anxiety or depression or whatever, and then you say, okay, I can take time point 1 or baseline resting state networks, and I can predict who's going to get better, but we already know who's going to get better at that point. So really, we want to move from post-diction to prediction in the future. So part of the problem was that we used to focus on the homogeneity, meaning we were looking at how patients were different from controls on average. And now we really want to capitalize on heterogeneity, since we know that there's patients are heterogeneous in many different ways, but especially in response to treatment. So following that vein, we looked at social anxiety, and we had 39 subjects with social anxiety. We did a 12-week CBT intervention, and we collected fMRI task. Oops. fMRI task, diffusion weighted and resting state. And we looked at the clinical ratings with the Liebowitz Social Anxiety Scale. And what we found is when we looked at the fMRI task activation to angry versus neutral faces, we found some interesting things I'll tell you about in a second. And then we looked at intrinsic connectivity as measured by diffusion weighted imaging with the inferior longitudinal fasciculus, as well as resting state in a hypothesis seed-driven way with the amygdala, as well as a data-driven way with the MBPA. So the first question is, why do we need brain imaging at all? So if you're a clinician and you have somebody come in, you're going to have a lot of behavioral and phenotypic and clinical information. You may already be able to predict the treatment response based on that. And in fact, when we looked at the initial severity of your anxiety, it already predicted 12% of the variance of treatment response. So it's possible that imaging won't add anything. When we looked at the fMRI task activation, however, what we found was that there was a region in the brain, in the occipital temporal area, that we found was predictive of outcome, in the sense that the more activation in that cluster to angry versus neutral faces positively predicted better outcome. And that was kind of surprising to us. We kept thinking amygdala, 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 but that wasn't the amygdala. And so that was an eye-opening lesson that we should really be doing data-driven approaches in addition to hypothesis-driven approaches. So when we looked at, but in the end, when we added the fMRI task to the initial severity, we increased the 12% of variance in treatment response to 41% of variance in treatment response. And then when we looked at the intrinsic connectivity as measured by resting state, now we went to do a hypothesis-driven, which was bilateral amygdala seed-driven. But we know that brain regions that are associated with the pathophysiology of a disease might not be the same regions that predict outcome. So we also did a very agnostic data-driven approach. So we did both the hypothesis and agnostic approaches, along with a diffusion-weighted approach here, where we're looking at the FA and to see if we could predict clinical outcome that way. And what we did was we combined both the intrinsic connectivity from the diffusion as well as the resting. And what we found was combining the intrinsic connectivity measures with the initial severity accounted for 60% of the variance in treatment response that substantially increased predictions based on the clinical measure. So really here we're showing that neuroimaging is helping in terms of prediction of treatment response. So that's all good. We can predict, we can do some early detection, but can we identify biomarkers early in life, perhaps even in children who are not at familiar risk, that predict their subsequent behavioral or clinical trajectory? How can we really take this to help people who might not even be at risk. So this is a final major study that I'll be talking about in terms of prediction. This is a longitudinal prediction of behavioral samples from a normative pediatric sample, where we have 94 typical subjects, 7 years of age. We scan them at 7 years of age, and then every year afterwards until they were 11. We again use the child behavioral checklist, and then we look to see if we could look at baseline connectivity measures to predict the subsequent progression of pathology as measured by the CBCL. So our hypotheses were simple. We pre-registered these analyses. We know that the MPFC, DLPFC anticorrelations are related to executive function. We know that selectively grow with development and decline with aging. And we know that there's a significant decrease in clinical populations who have cognitive impairment. We know that the subgenual ACC is related to depression. And we also know that the subgenual ACC, DLPFC has anticorrelations in those children who are at risk for depression. So our hypothesis was that the MPFC, DLPFC anticorrelations would predict worsening of attention. That's what we see here. We placed a seed in the MPFC, and what we found was that the degree to which the MPFC and DLPFC are negatively correlated at age 7 positively predicted increase in attentional problems, whereas the more the MPFC and DLPFC were positively correlated, predicted worsening of attentional problems. Now, on average, the MPFC and DLPFC at this age is positive. But what's really nice about this is that even though on average it's positive, there's enough individual differences that even at age 7, you can figure out who's vulnerable, who's going to get worse, meaning the people who get worse have positive correlations at this age. If you're a 7-year-old kid and you have positive correlations in MPFC and DLPFC, you're more likely to get worse in attentional problems. It's reflective of ADHD. And if you have negative correlations, you're more likely to get better. So if you look here on the x-axis, you'll see the worsening of attentional problems. So the positive means getting worse, and the negative means you're getting better. And then you'll see here on the y-axis that there's many people who actually don't change at all, but that's not surprising because it's a normative pediatric sample. So this is just showing you that we can tell at age 7 who will progress to ADHD-like symptoms, who will get worse, and who will stay the same. When we look at the subgenual ACC, we know that the degree to which, we hypothesize that the degree to which the subgenual is negatively correlated to the DLPFC may have something to do with anxiety and depression. And in fact, what we saw was the degree to which the subgenual ACC and DLPFC were negatively correlated did predict a worsening of internalization, which was driven by anxiety and depression. But that's all good and fine, but how do we really translate this clinically? One question would be like, okay, that's fine in the sample, but can you replicate it? Before I want to show the replication results, I do want to mention that the left DLPFC subgenual ACC in relation to MDD or depression does make sense in the literature, because we know from Helen Mayberg's work that deep brain stimulation of the subgenual ACC results in attenuation of hyperactivation in DLPFC. And the left DLPFC region that shows maximum anticorrelation with the subgenual is being used to target TMS to cure depression. And subgenual ACC has been shown to exhibit decreased connectivity with cognitive control regions in children who have a history of preschool depression. So it kind of lines up with the literature to make sense that way. But can you replicate it? So we took this model, and then we went back to the children I mentioned a few minutes ago, the children who were at risk but were not diagnosed with depression. And we followed those children, and we said, okay, let's use the same models to see if we can predict who's going to get worse and not. So again, we use a subgenual seed, and what you'll see here is the degree to which the at-risk are at blue and the no-risk are in red, the degree to which the subgenual ACC is anti-correlated or negatively correlated to the DLPFC predicts a progression of anxiety and depression for those children, which subsequently then predicted conversion. So then we had another data set, which was from a human connectome and disease. Here we have 225 adolescents with anxiety and depression. And this is in partnership with MGH, McLean, and Boston. And what I found here was that this is from the children who are at risk. If you place the same seed in the subgenual, this is what the DLPFC region that related to a progression of anxiety and depression for children who are at risk. this is the same model looking at those teens who were already anxious and depressed, 14, 15-year-olds, but we followed them a year later, and we followed how they did on the CBCL measure. And again, the degree to which they were negatively correlated predicted a worsening of anxiety and depression. And as we get these people back, this is a fourth year on the grant, so we're continuing to follow these people. And as we follow these people, we still see the same relationship. So finally, I'll talk a little bit about predicting psychosis. So this is a study in collaboration with people at Shanghai. And here we have 93 controls, 158 clinically high-risk individuals for psychosis. And we have a structured interview of prodromal symptoms to relate to the brain data. And just remembering way back in the day when we had a small n, but we did have a relationship between the degree to which the MPFC and PCC, the self-reference nodes, were tightly coupled, significantly positively related to positive symptoms. And that was just a straight correlation analysis. But now we have a big enough n to actually do a prediction analysis. And so here we find the same thing, the MPFC and PC positively, and true prediction now, predicts those who are at clinically high risk progressing in positive symptoms. And then we also looked at the topology with graph metrics, and we found the modular organization of the functional connectome was abnormal in converters, but not for non-converters. So here you'll see the healthy controls. Here you see that those individuals who are at clinical high risk that did not convert, and those who did convert. And you'll see the areas in yellow where the limbic system is now reallocating essentially the allegiance over from where it used to be to the sensory motor is now to the dorsal ACC. And what was interesting is when we looked at the abnormalities of the module assignment, we found regions that were specific to schizophrenia and auditory hallucinations, like the STG, regardless if we did the surface or atlas-based MNI parcellation. The STG was by far the most significant there. So we wanted to figure out, okay, if we know the STG is relevant for this, how can we modulate them? We know these resting state networks are plastic, how can we actually modulate? So before we wanted to modulate with real-time fMRI, we wanted to think about some hypotheses. And one hypothesis that was interesting was from Georg Northoff, first of all, we know that the STG is high prior to and during auditory hallucinations. And Northoff and Quinn have posited a hypothesis that the MPFC and STG is actually hyperconnected during rest, and that may be related to the personal salience of auditory hallucinations. And so we had the question, can patients actually learn to downregulate the DMN, and would that have a subsequent modulation of the DMN STG connectivity, and would it have any effect on the auditory hallucinations? So we found indeed that both the converters and non-converters had hyperconnectivity of the MPFC and auditory cortex. So we had subjects the patients come into the scanner, and these are now chronic schizophrenic patients. And we basically did a resting state scan first, and then we did a functional localizer. We did an ICA localizer to figure out where their DMN and central executive network was. We put them in the scanner, we scanned their brain, and then we fed back the degree to which they were modulating their default mode network and central executive network. So this is what the subject is seeing, and this is what the experimenter is seeing, and I'll show you that in a little bit more detail. So here, again, we individualize the default mode network and central executive network, and we'll see here to the left is what the experimenter is seeing, and what you'll see to the right is what the patient is seeing. And what we are doing is we're training them to do a mindfulness meditation task, because we know mindfulness decreases the DMN, which is a good thing, and also it increases the central executive because you're paying attention. And what we want is we want to kind of increase these anti-correlations. So we basically train them outside of the magnet to push down their DMN with mindfulness meditation and increase their DLPFC or central executive network. And so the ball here, the game, what they see is a game. And the game is that they have a white ball here, and they can move the white ball into the yellow circle. They can move it up into the yellow circle. And the only way they can move it up is if their DMN is higher than the central executive network, and the hop size of the ball moving up is proportional to the magnitude of the difference between the DMN and central executive network. That's if they're in a good brain state. If they're in a bad brain state, meaning that the default mode network is high and the central executive is low, then the ball goes down. So they're trying to push the ball with their brain state. And here's an example of a subject who was not able to do it at all at first, and then after a couple of runs was actually able to do it. So here the DLPFC is in purple, the PCC is in green. Now he's actually moving the ball with his brain state, and now he's separating them. You see the PCC, the DMN is low, the DLPFC is high, he gets in, and it shrinks to make the task dynamically more difficult. And you can see how well he's separating these bold signals. So that was a really good patient who did remarkably well very early on. And it turned out that on average, when we did this with a number of people, what we found before we did this intervention, we found hyperconnectivity of the default mode network. But after the intervention, we found a significant decrease in the MPFC-PCC connectivity and an increase in the MPFC-DLPFC anticorrelations. And then when we used a sham condition, so if you were feeding back a different area like in motor control and looked at the difference between the resting state networks while they were doing mindfulness meditation, we did not see these changes in the resting state networks. So that means that it is a combination of the mindfulness meditation along with the real-time fMRI. If we had seen the same modulation of networks, and they were just basically using mindfulness meditation. But I think in this case, it's clearly the combination of the mindfulness and the real-time feedback. So the other thing that we noticed is we did see initially hyperconnectivity of the MPFC and STG that was remarkably reduced, and the degree to which the MPFC-STG was reduced positively correlated with significant reduction of auditory hallucinations, which in the end is our ultimate goal. We want to reduce auditory hallucinations. So the reduction of MPFC-STG correlated with the reduction of auditory hallucinations. And finally, I'll end with pharmacological modulation that may be more pertinent now that cannabis is legal in many states, and also cannabidiol is being considered for standalone treatment for schizophrenia. We know that 42 to 65% of patients with schizophrenia have co-occurring cannabis use disorder. And so here, in collaboration with people at Dartmouth, we had patients come in, there was a bong in the scanner, we had them take marijuana, we had them also do dronabinol, and we had a baseline resting state scan, we did an intervention, and then we did another resting state scan. And so what we found is, again, we had hyperconnectivity of the self-reference nodes, MPFC and PCC, in the patients with co-occurring cannabis use. And that also related to the positive symptoms, and that was normalized after the intervention. In other words, there was no between group difference. We also found in time 1 a nice anticorrelation in the controls, not in the schizophrenic patients at all, which is what we typically find, but a dramatic increase in the DMN anticorrelations after the intervention for both cannabis and THC. And in addition to that, the degree to which the MPFC-DLPFC anticorrelations improved significantly correlated with an increase in working memory performance. So that's kind of hopeful if cannabidiol really can be used as a potential standalone treatment for schizophrenia that could potentially help ameliorate some of the positive symptoms and perhaps maybe even improve cognitive impairment. So today we talked a lot about many different ways of using resting state networks for clinical translation. And I'll leave you with a thought that maybe in the future, could children get help before they're in crisis through early identification, get treated more effectively through better direction and better precision to available therapies, and possibly have options for novel therapies like real-time fMRI feedback. So I wanted to thank all my colleagues, all of my technical colleagues, all my colleagues at MIT and now Northeastern, as well as all my clinical colleagues and my real-time MRI and all of my human connectome collaborators. So thank you. Any questions?
Thank you for an incredibly interesting talk. Thought-provoking. I wonder if you could talk a little bit about the difference between correlation and correlation. You know, when you use the scanner, when you measure anticorrelation, as it the direction of a correlation, is that necessarily the same as measuring power? You see where I'm going?
So, in terms of are you just shifting over the correlations in a sense?
So, right.
Is there
The magnitude of those thing and a positive correlation?
right? So, what is a positive correlation versus a negative correlation, essentially? Yeah. So I think depending on what kind of processing you do, it could mean different things. And hopefully, in the way that we've done our processing, we can actually interpret them in a very specific way. And I think when you have these negative correlations that seem very tightly coupled to executive function and consciousness and things like that, they actually are quite meaningful. And the more negative they are, the better you're able to attend to the outside world, the better you can toggle between internal and external processing, the better you do on complex working memory. And we've seen that we can actually modulate these anticorrelations with things like mindfulness meditation. For instance, we did a wide-scale intervention with in Boston, where we went into 6th grade schools, and I shouldn't say intervention, I should say we did mindfulness with 6th graders in many Boston different schools, and then we trained them how to do mindfulness meditation. And so the first thing we did was we looked at a task where we looked at the amygdala, and it was more activated for fearful versus neutral scenes, and the degree to which it was more activated in the amygdala correlated with perceived self-stress. And then when we looked at the resting state connectivity, we found that the mindfulness meditation increased the anticorrelations, and the degree to which they increased the anticorrelations correlated with an increase in performance on the START task. So it seems like a sustained attention could be related to these anticorrelations. So we have complex working memory, kind of attention, memory, things like that. That's the way I see the anticorrelations a little bit. Yeah.
Just curious about how sensitive the kinds of analysis you're doing are to precise location of the seed.
That's a fabulous question. So the question is, how sensitive are these analyses to precise location of the seed? And I think that's a fabulous question, especially when we're looking at children versus versus adults versus you might have some brain pathology in patients, and it's an excellent point. And so what I try to do is I try to use it depends on the region. So if it's something like the nucleus accumbens, something that's really small, I try to get a very specific anatomical region that is specific to that very person. Or for instance, we were looking at patients who have heterotopia, so they have nodules deep inside the brain, and we want to, and that causes epilepsy. And so we want to TMS that, but we can't TMS it because it's a very deep brain. So in that case, we draw a region around that particular person's nodule, and we look for cortical targets or cortical associations, and then we use TMS to adapt that to try to help epilepsy. So in that case, it's very specific to the individual. But your point is well taken, that if you use like one generic seed, you can have different anatomy and function for various different people. So for every different analysis technique, whether it's ICA or seed-driven, you're going to have to make some choices. In ICA, you have to figure out how many components and what. So the more specific the region is, the more specific I like to have the seed, and the more individualized I like to have the seed. If there's less heterogeneity and individual differences, and there's a more less heterogeneity in terms of the spatial area of like the medial prefrontal cortex and healthy adults, and I could keep one seed for everybody. But we do have ways to make it very specific on an individual basis. That was a great question.
I was really interested by the data trying to go from post-diction to prediction.
Yeah.
But I just wanted to ask you, so you put up one slide where you pointed out that there were a bunch of kids that did not change from.
Yes.
So I guess my question is there a difference then in your mind between prediction and diagnosis? That is, I want an individual child to know whether I should intervene. And it wasn't clear to me from the data that you could actually do that, because you didn't yet know if that child was going to change or not. Just as a group, you saw this correlation.
Exactly. So the next step is that we're trying to make height and weight charts, growth charts. We're trying to do that with brain data. And so then you basically take the magnitude of the anticorrelation or whatever the subgenual DLPFC, you say, okay, here's my measurement for that particular kid.
So,
where does it fall? Exactly. And
right,
then,
so my follow-up, and I think that's what you
Yeah.
just said, is
Yeah.
that, you know, you in those data, you sort of like had a snapshot and a snapshot.
right.
But if you take 2 or 3 snapshots over some period of time, you might then see a trajectory.
Exactly.
Then
So
give you
I love the questions. Exactly. So that's actually what we did. I didn't show this here because I didn't have enough time, but that's exactly what we did. We did have a trajectory. Exactly. We do analysis that way. And we also looked at mechanism, not only prediction. So we looked at how does the brain change, say, from the MPFC and DLPFC, has a resting state functional connectivity of the MPFC and DLPFC relate to the change in attentional problems. And so we looked at that as well. And that looked very nice. But these are all excellent questions. Yeah.
It's really amazing work. I have 2 questions about the neurofeedback. So, so one question is, do you have any data now on how long lasting?
That's a fabulous question. So the initial grant was a 2-year R21, and we didn't get any results for a long time. And it wasn't until I started doing mindfulness meditation on the default mode network that we actually ended up getting good results. It's a long story, but at the end of that, we did get some good results, and they did have subsequent reduction in auditory hallucinations, but we ran out of money. And so now now that we got results, we have now a 5-year R61, R33 grant. And so now we're just now starting to look at the duration. And that's an excellent question. That's really, really what I know.
Great. Now that you've given that answer, I have 3 questions. So the protocol that you described, and you had the video,
Yeah.
That's not what you're calling mindfulness.
No, sorry, I was rushing through that. But basically, we train them to do a mindfulness noting task prior to getting into the scanner. And so, and then when they get in the scanner, the ball game they are doing while they're doing mindfulness meditation. So it is kind of a dual task. So they're doing mindfulness meditation and they're watching the ball go as they're doing the mindfulness meditation. And it's amazing that the patients love this because they can actually feel like for the first time they actually can, control their brain, and they're so thrilled. And it's also kind of nice even for controls, because usually when you do mindfulness meditation, you don't have any visual feedback of how you're doing. So it's kind of nice on both. And I'm hoping in this round that we can actually have them, train them to do mindfulness meditation, in between. We're going to scan them 6 times over a long period of time. And we're going to, see the change of resting state networks and track this time I'm also going to track working memory performance and other executive function measures and see how their auditory hallucinations change over time.
Sort of ties into the final question. It's I'm curious about with the neurofeedback protocol, how much you have to worry about unintended effects, right? And so maybe you're doing this amazing thing in your target area, but could you be having negative impact on other emotional or cognitive?
Right, so there's 2 parts. So the question is, having any other negative impact? I worry about that more with something like TMS. With this type of thing, we have never heard any self-reports of anything getting worse in terms of psychopathology. We do ask them all these different questions. They seem extremely happy. We are probably, when we are targeting the default mode network, we are probably changing, in fact, for sure, changing other regions of the brain, like the STG, which is related to auditory hallucinations, but luckily that's actually going down. Does it relate to, is it changing other parts of the brain that may be bad? I don't think so. We haven't seen none of the psychopathology measures that we are getting are going worse. So I would, but it's an excellent question, because as soon as you start tampering with the brain, you want to make sure that you're not causing, other negative side effects that could result. Yeah.
So you're sort of getting at this, but can you say a little bit about the mechanism that would connect feedback and change the default network to lowering auditory hallucinations? So, is there a theory of why those things?
I would love to answer that. So, I'll send you a paper by Georg Northoff, and it was his original resting state hypothesis that it's possible that the anterior hub of the default mode network, namely the medial prefrontal cortex, may be hyperconnected or correlated to the STG. And I don't have an answer to that question. It does seem intuitively possible and interesting that you can imagine that the default mode network in patients with schizophrenia may rope in the auditory cortex. I could see that. I could some potential hand waving mechanisms, but I don't feel comfortable doing that at this point. But they do seem empirically to be related in the sense that we do, in some sense, have a causal relationship in the sense that we have a pure resting state. We do this intervention on the default mode network, and then we have a subsequent reduction of the MPFC-STG connectivity, which does relate to a reduction of hallucinations. So I think there's some causal evidence, and I don't have a mechanistic answer for you.
Thank you very much for.
Thank you so much.
Hi, can I ask a question?